Hi, everyone, and welcome back to Fit to Fellowship, a survival guide for the first year general cardiology fellow. I'm Megan.
And I'm Stacy.
And welcome back.
And today we have Dr. Curtis Stinnis from Scripps Clinic, who's going to be talking to us about access complications. So here's an introduction on Dr. Stinnis. He is the Director of Peripheral Interventions, Division of Cardiology. Dr. Stinnis is an interventional cardiologist who is nationally recognized for his expertise in minimally invasive catheter-based procedures for the treatment of coronary heart disease, valvular heart disease, and peripheral arterial disease. Dr. Stinnis received his medical degree, his internal medicine residency degree, as well as his cardiovascular fellowship degree, all at UC Irvine Medical Center. And he did his subspecialty in interventional cardiology at Scripps Clinic, Scripps Green, which is where he currently practices interventional cardiology. Dr. Stinnis is board certified in internal medicine and interventional cardiovascular diseases. He joined Scripps Clinic Medical Group in 2008 and is a member of the American College of Cardiology and American Medical Association. So let's tune into Dr. Stinnis's talk.
Hello, and thanks for joining. Today, we're going to talk about managing access site complications. This is primarily intended for the very beginning of your fellowship, so we're not going to go through every possible detail, but kind of a large overview of how to manage access site complications should you get called as a fellow to address those. So it's your first night on call as a cardiology fellow. Your pager goes off and the nurse says, there's a patient who had a heart cath procedure earlier today and the access site is bleeding. Can you please come and address that? This can tend to instantly induce fear and anxiety in a new cardiology fellow who doesn't have experience with access site complications and doesn't know what to look for. So we're going to walk through some of this to try to make you, more at ease with dealing with the situation. And these are skills that you will develop further and further as you do catheterization procedures during your fellowship. So obviously, we've switched a lot to doing radial access, and it certainly has been a game changer for cardiology in general. Certainly, if you look at the data, radial access has reduced complications as compared to femoral access. However, you'll notice that the complication rate for radial procedures is not zero. So there can still be complications with radial procedures, and we'll discuss that. So if we look at vascular access in 2021, radial catheterization is clearly an important innovation in cardiology, and it works very well for the right patient with the right situation. Very skilled operators can probably perform about 80 to 90% of their cases from the radial approach, but many of these cases will still require femoral access. Peripheral interventions, Impella cases, ECMO, very complex anatomy cases, TAVR procedures, and other structural heart procedures. And of course, if there is no ability to access the radial artery due to aberrant anatomy, tortuosity, spasm, or radial artery occlusion or harvest. And of course, as we mentioned, radial artery access sites can still develop complications. All right. So what you need to know here about vascular access site management is that some access site complications are due to poor access technique, and some are due to poor closure or hemostasis technique. And it's really important to understand the principles for obtaining good access and the anatomy involved if you're going to understand how to manage these access site complications. So as the person on call who's coming to address a patient who has a potential complication, you obviously don't have control over how the access was obtained, but you have to have some knowledge of it in order to better manage it. So let's go through some basic anatomy. This will be a refresher for you from gross anatomy in medical school and other experiences such as general surgery, etc. So on the left side of your screen is obviously a cadaver and showing you the main structures in the region of the femoral artery. We have the femoral nerve, the femoral artery, and the femoral vein. Importantly, we can't see all of these things on fluoroscopy, which is what we're using in the cath lab to obtain access. But we have to know where some important structures are fluoroscopically, and we're going to talk about what these are, but basically the external iliac artery comes down in the pelvis very deep. It then rises over the pubis and becomes the common femoral artery. By nomenclature, the common femoral artery begins once the external iliac passes under the inguinal ligament. There's a very important artery or branch that comes off called the inferior epigastric artery, which we'll talk about, which you need to know and understand. The common femoral artery then by convention ends where the bifurcation of the superficial femoral and the profunda femoris are. And every patient has a variable anatomy in this regard. We have the so-called high bifurcation and the so-called low bifurcation. But for purposes of nomenclature, the common femoral artery begins at the inguinal ligament and ends at the femoral bifurcation of the profunda and the SFA. Now, here's the inferior epigastric artery that we discussed earlier. Importantly, we can't see the inguinal ligament on fluoroscopy because it is a soft tissue or a non-calcium-containing structure. But we know where it is because the inferior epigastric typically arises off of the external iliac, goes underneath the inguinal ligament, and then goes along the anterior wall of the abdomen to anastomose in the chest with the internal mammary artery. And so the nadir, or the lowest point of the inferior epigastric, is a good surrogate marker for the location of the inguinal ligament. Now, if we were to think in 3 dimensions, if we were to put our head at the side of a fluoroscopic image, fluoro is only 2 dimensions. So in this picture, you can't really appreciate that the external iliac is much more posterior than the common femoral, and that the profunda is typically a posterior vessel as well. They all look to be in the same plane. But if you were to look at this structure from the side, as I've drawn for you here, you would see that it's a very different story. The external iliac artery is very posterior in the pelvis. It then rises up, goes under the inguinal ligament, becomes the common femoral artery, giving off the inferior epigastric artery, which then again goes north along the abdominal wall. The common femoral artery then continues until we have the femoral bifurcation, which again is variable depending on the patient. Once we have that femoral bifurcation, we no longer have the common femoral artery. Of note, the profunda femoris is a very posterior vessel, and it travels deep into the thigh in most patients. Now, importantly, the most important thing you need to know about this relationship is that when we do a manual hold, when we obtain hemostasis by compression, what we are doing is we are compressing the region of the common femoral artery, which is over the pubis. So this pubis is extremely important for access control. A lot of people talk about the femoral head and using the femoral head for guidance, but the reality is that the common femoral artery really has very little to do with the femoral head. If you look at this CT scan of this patient, you'll see that when you change the angulation, you'll see that the common femoral artery is really riding over the pubis, and this is the location of where you're compressing it. You're not compressing it on the femoral head, you're compressing on the pubis. Therefore, when one gets access, one needs to get access over the pubis so that it is compressible. So again, here's some more images to show you that. On the right side is obviously an OR picture with a live specimen with a dissection. You can see the external iliac artery, which is coming from very deep in the pelvis, coming over the pubis. And this is the location of optimal access because this is the posterior bony structure that we get compression against. So what are we doing when we do a manual hold? Really what we're doing is we are applying pressure to prevent exsanguination and bleeding and hematoma formation long enough for the arteriotomy to recoil back down because it's been stretched by a sheath to a small hole, and then a small thrombus forms. So that's really what we're doing. So this requires 2 things. Number 1, appropriate pressure. Number 2, appropriate pressure in the right location. And number 3, a posterior structure to compress against. If one of those things is missing, it will not be an optimal hold. How do we hold proper pressure? Well, the key is to get point pressure over the right place. This is a typical hand position of what is most comfortable for many people. Most of us are not strong enough with just 1 finger or 2 fingers to apply the needed amount of pressure for the needed amount of time without using our other hand to kind of help push down. But the key is you notice that this is the fingers and not a fist or an open palm. We want point pressure so we can concentrate that force in the right place. And it turns out it requires about 50 pounds of force to adequately compress a femoral vessel for most patients. Now, for a thin patient, less force may be required. For a larger patient with a deeper artery, more force will be required. If the artery is more calcified, more force will also be required. But on average, about 50 pounds of force is required. Now, how do we do a manual hold? And again, this is important to know because if there's a bleeding complication and you are called to address it, you need to know how to take control of this and get proper control using a manual hold. The compression should be forceful enough to prevent bleeding and oozing and hematoma formation, and allowing that formation of the clot to form at the arteriotomy, as we discussed. The rule of thumb for compression is about 2 minutes of compression for each French size of the arteriotomy. What do I mean by that? That means the hole in the artery, the size of the hole in the artery. By convention, sheaths are standardized by their inner diameter. So a 6 French sheath has an inner diameter of 6 French, but it doesn't tell you anything about the outer diameter of the sheath. Thicker walled sheaths will make a larger hole in the artery, even though they may still be 6 French. So it's important to know the outer diameter of the sheath, and we time our holds based on the outer dimension of the sheath because that's the size of the hole. So on average, if you increase the size of your sheath by about 2 French sizes, so in other words, if you're doing a manual hold on a 6 French sheath and you would assume the outer hole is about 8 French, that's fairly accurate. So we're going to take that and we're going to add the 2 minutes per French size, and that's typically what we're going to apply for a manual hold. We're going to apply pressure over the entire estimated compression time and gradually reducing that pressure as bleeding is controlled. The key thing is don't peak, because if you let go of your pressure too quickly, bleeding will occur and you sort of have to start the process all over again. So the key is there's no peaking. So you need to have adequate hand strength to apply that pressure for that necessary period of time. So let's talk about how to hold an artery versus a vein. Now, this may seem obvious, but occasionally there are mistakes made. So the artery obviously is bringing flow this direction. So that's the arteriotomy, and we need to hold pressure just above that area to reduce flow. For venous hold, we want to hold pressure below the venotomy site because blood is returning back to the heart. If we hold above, it will bleed out. Now, keep in mind, if the patient has very elevated venous pressure or has severe tricuspid regurgitation, there may be pulsatile or very elevated flows in this area, and you may need to hold the vein both above and below the site if it's bleeding because of that issue. Now, what's happening when we do an external compression? So again, going to that lateral view that we showed earlier, when we push down on an appropriate location, we're compressing that artery against the pubis and we're obtaining hemostasis. If the site of access is too high and is in the external iliac artery, for example, pressing on the abdomen will not be able to compress the artery. It simply deflects the artery or deviates it off, but will not compress it. And the blood from this location will then spill into this large open cavity, which is the path of least resistance, and that is the retroperitoneal space. These high sticks ostensibly are the easiest manual holds because you almost never will see bleeding at the skin site because the blood will not track through the path of highest resistance through the soft tissues, but instead into this large open space that it's actually already in, the retroperitoneal space. So it can be very deceiving where you don't see any bleeding and you think that you've done a great job, but the reality is the patient is internally exsanguinating, and we'll talk more about that later. Likewise, if the site of access is too low and is below the pubis, when we do a manual hold, we can't fully compress the artery. We may prevent a large hematoma from forming, but an access that's below the pubis is more likely to develop a hematoma or what's called a pseudoaneurysm because there's no posterior structure to compress against. But pressing down on the soft tissues confines that area very tightly with soft tissue. So the hole in the artery may not close, but it can confine the bleeding to that space and create a persistent tract, and that's known as a pseudoaneurysm. So rather than using the conventional definition of the common femoral artery, which is the simple anatomic definition, as I mentioned, from the inguinal ligament to the femoral bifurcation, we would prefer to use the functional common femoral artery, which is that version or that portion which is directly over the pubis, because that's the optimal location for a manual hold. Let's look at some femoral angiograms because, as we'll discuss, that's the first thing you're going to want to do when you're dealing with a patient with a potential bleeding issue in the groin. This is an example of ideal femoral access where it's right over the middle of the pubis and very compressible. This is an example of access which is too high. Remember, we talked about the inferior epigastric artery. The nadir of it is right here, and the sheath essentially goes in right there. So this is actually probably going through the inguinal ligament, and this is a very high risk for retroperitoneal hemorrhage. This is a very, very low access site. This is in the superficial femoral artery, a good probably 5 or 6 inches below the pubis, and it's at such a steep angle, the sheath is actually kinked, and we'll talk about the significance of that later. This is another common question is, well, what happens if the site of access is not in the common femoral? Well, here's the thing. As I mentioned before, some patients have a high bifurcation. This patient has a very high bifurcation. If we were to get access in the common femoral artery, there really isn't one. And you see, here's the inferior epigastric. If we actually accessed the common femoral, we would be, by definition, be in the retroperitoneal space. So this sheath, although it's in the superficial femoral artery, is over the pubis and is compressible. And therefore, we don't really care what the artery is called. We just care that it's over a compressible location over the pubis. That's what matters. So how do we manage these situations? If you're called to see a patient for suspected femoral artery access site bleeding issue, it's very important to look at that femoral angiogram. You want to make sure that that site of access was over the pubis. If it was a high stick, then likely the patient is suffering from a retroperitoneal hemorrhage, and we'll talk about how to manage that in a bit. If the stick is low, it's going to be challenging to get appropriate compression of that location externally because there's no posterior structure to push against. And so it may be more challenging to control the hematoma or the bleeding at that site because of that fact. Here's an example of a serious problem that you don't want to happen, but has happened. So this is obviously a very high stick. It's well above the inguinal ligament. It's actually in the external iliac artery. This patient was sent to a recovery area to undergo a manual hold, and shortly thereafter became hypotensive. It would be very, very obvious to you why this patient was hypotensive if you looked at this femoral angiogram. It doesn't take a rocket scientist to diagnose this. You know this patient has retroperitoneal hemorrhage. And so looking for other things that cause hypotension would waste valuable time and potentially lead to this patient's demise if this is not addressed quickly. Here's another example of a serious problem that can cause retroperitoneal bleeding. This is a laceration of the inferior epigastric artery. So what you're seeing here is this is the inferior epigastric, and you see there's actually a laceration here from a needle puncture with blood exsanguinating out, contrast exsanguinating out, and you notice that the patient's bladder is also shifted all the way to the left. That's because there's a massive retroperitoneal hemorrhage happening here. This patient was taken urgently back to the cath lab, and this was coiled off, and the patient was resuscitated. Here's an example of a seemingly okay stick, right? This is in the common femoral artery by the anatomic definition, but it's not over the pubis. And this patient was somewhat obese, was sent for a manual hold, and developed a large growing hematoma. And the reason for that is this could not be compressed properly. Now, a lot of people say, well, I don't understand. Can't I just hold pressure here at the pubis and that will prevent bleeding? Well, it turns out, no, it will not. And the reason for that is our bodies are loaded with collateral networks. There's an extensive collateral network between your internal iliac artery and your profunda femoris. So what happens is you go ahead and hold this area with your hand here, and what's happening is blood is actually going through those collaterals down to the profunda and then back bleeding retrograde and out through the hole. That's why when a vascular surgeon cuts down to repair an artery, they have to clamp the artery north and south of the hole because of the back bleeding. So just holding here will not get control of this. That's why it's so important to get access in the right place. Here's an example of a patient who developed a very large hematoma in the recovery area before the sheath was even pulled. And it was so large it couldn't be controlled. And the patient was brought back to the cath lab. And you'll see here that when contrast is administered through the sheath, there's a large area of extravasation of blood near the area of the sheath, either due to multiple vascular punctures or some other injury to the artery that occurred during access. Now, many places will use this device for compression. It's called the femostop. I affectionately call this the vascular complication creation device. The issue with this is an external compression device where a strap is wrapped underneath the patient. This is then placed across the femoral site, and then this bulb is inflated, and this plastic area is inflated and puts point pressure. Now, it seems like a great idea. The problem with this is in a thin patient, it works fairly well. In a larger patient with some obesity or pannus, it often slips down because of the obesity. And then it's actually holding pressure distal to the arteriotomy, which accentuates bleeding. Also, the problem with this is I find that it gets abused as a quote unquote set it and forget it device where it's put on and the nurses go about doing other things and the patient is left unattended for quite a long period of time. That can lead to this device moving or failing to obtain hemostasis and developing bleeding, or too much compression and loss of distal pulses if it's left on for too long. So it has its downsides. And again, here's what I'm telling you about the obesity. If there's somewhat of a belly here, if you will, it pushes down on the device if the patient coughs or moves, and it can slide down, causing the blood to then have no other place to go but just accentuate bleeding and go north. So if you are called to a patient because of a concern of a hematoma or bleeding or lack of pulses in the extremity and there's a femostop in place, first thing you should do is remove the femostop and get control with manual pressure. Don't simply try to reposition the femstop and inflate it some more, because you don't know what's going on. You need to get control the old-fashioned way, the proper way, frankly. Here's an example of a patient who, again, got a femoral hematoma with the sheath still in place. So again, if you're called to assess a patient who has a sheath in and they're appearing to develop a hematoma, what you don't want to do is then just hold pressure, because many of these sheaths are very thin-walled, and this was an attempt at holding pressure, and the sheath became kinked, and you can see it's actively bleeding here. So if the sheath is still in place and the patient does have a hematoma, you need to get control. You have two options. You can either remove the sheath and immediately do a full proper manual hold, or you can replace the sheath over a wire for a braided sheath, which is what was done in this condition, this case. This is a braided sheath, which isn't something that you can kink very easily. And once the sheath is in, they were able to hold pressure and control the hematoma. So one of those two things will work, but you don't want to hold continuous pressure with the sheath in place, because it's propping the arteriotomy open with the kink and it will continue to bleed. All right, let's talk about some complications associated with femoral access. There are many complications that occur, but for purposes of this talk, which is you're a brand new fellow, you're getting called when you're on call to manage a patient who's already had a femoral access site performed, we're not going to talk about the complications that can occur from pure access, because you have no control over that. So we're going to talk about the ones in red, which you do have some control over. Let's start with hematoma. So what is a hematoma? Well, in simple terms, it's a loss of blood under the skin due to bleeding from an underlying artery or vein. And this is more than just a bruise. This is a hard lump that's filled with blood. This can be very painful for patients, obviously. A stable hematoma is one that's happened, but it's not continuing to grow in size. An unstable hematoma is actively growing due to continued bleeding, and this is something that is a serious situation and needs to be handled right away. Here's some examples of some hematomas. The one on the left is quite large, and this is a very large hematoma that would be very difficult to control with manual pressure, because A, you don't really know where the arteriotomy site exactly was, because there's so much blood present and so much shifting of the skin. Number two, trying to get that point pressure on the artery is impossible, because if you try to put point pressure, there's so much blood, the force that you're pushing down just gets diluted out, to the left and the right and north and south, and doesn't adequately put point pressure on the artery. So a large hematoma like this needs to be managed in a different way, and we'll talk about that in a moment. This is obviously a very nasty bruise, but this is a relatively soft hematoma that was sort of mashed out and was controlled. So this is the most common access site complication you're going to see. A hematoma is definitely the most common access site complication. This can be due to a number of things: multiple punctures, or somebody using a through and through puncture technique, poor hemostasis with a closure device that failed or didn't work, or somebody did a lousy manual hold and led to a hematoma. If there's laceration of adjacent vessels, like I showed you earlier, if the sheath is kinked, it can lead to a hematoma, as I discussed. And if the access site is not over a bony structure and it cannot be adequately compressed, this can lead to a hematoma. And any of these can be exacerbated or worsened by anticoagulation, obviously. So how do we manage hematomas? Well, a small hematoma can be stabilized and resolved with good manual pressure held just above the access site, as I discussed. A large hematoma is nearly impossible to manage with external compression alone. It's impossible to get that point pressure on the artery, as I discussed. Often pressure is distributed too widely, and this will fail to get control, but it will also, in the process of doing so, injure other structures, like it'll actually inadequately compress the artery, but it'll compress the vein or compress the femoral nerve, both of which are not ideal. And if we're holding pressure incorrectly and it's distal to the arteriotomy, you can actually accentuate the hematoma. So if you have a large hematoma, like I showed you before, the best management strategy for this is what's called rapid internal tamponade. And what that means is the patient needs to come back to the catheterization suite. We need to get inside there and put a balloon inside and adequately control that hole from the inside, since that's the only way we're going to be able to solve this. It might require further management with a covered stent or possibly surgery to repair. And of course, we may need to give the patient supportive measures like fluids and or blood transfusion, etc. Here's an example of such a case. This is a 78-year-old patient, morbidly obese, who had a PCI procedure, a stent procedure, from the left groin. Patient had a manual hold performed in the recovery area. During the process, a large hematoma began to form and continue to expand. There were 3 or 4 people pressing down on this, trying to get control, none of which were being successful because of the size of the hematoma. Patient was hypotensive, got some fluids, was hypotensive again, and then was taken back to the cath lab. And this is an example of internal tamponade. We've got an access from the other groin. We're up and over, and we've got a balloon right across that hole and blocking flow. And you can see the contrast that has filled this massive hematoma cavity. This is the only way you're going to get control. External compression isn't going to work. After control was obtained, the patient was taken to the operating suite, had the hematoma drained and cleaned up, and then the femoral artery was repaired. The other thing about internal tamponade is that this also provides a proximal occlusion to make it easier for a vascular surgeon to get in there quickly and repair the artery. What you don't want to do is have a massive hematoma like that that's still growing and just take the patient straight to the operating room. The reason for that is it takes time for a surgeon to be present, to get the operating room available, and that process could take 20, 30, or even 40 minutes. This patient doesn't have that much time. They would potentially exsanguinate or have serious thigh hematoma or even compartment syndrome if that were left to happen. So we need to get immediate control internally, stabilize the situation, and then determine a definitive course of action. So again, small hematoma, apply that firm point pressure just above the arteriotomy site. It's helpful to mark the borders of the hematoma to make sure it's not getting bigger. And you want to, of course, provide adequate sedation to the patient and explain what's happening to help reduce anxiety, because this can be painful. They tend to get nervous when they see sort of people wrestling around them and doing things quickly. It helps to reduce their anxiety by explaining what's happening and to also give them sedatives. If you have, again, a large or growing hematoma, you need to, of course, apply firm pressure if you can. If you can't get control, call your interventional cardiology team STAT, have that patient brought right back to the catheterization suite, and to have internal tamponade performed to gain control. So that's hematoma. Let's move on to pseudoaneurysm. We talked briefly about this, but what is a pseudoaneurysm? Well, a true aneurysm is a outpouching or bulging of an artery that still has the artery wall confining it. A pseudoaneurysm is a hole in the artery that failed to close due to, again, poor hold technique or inappropriate site of access, but it's not a growing hematoma because it's been walled off by soft tissue, but there's a persistent leakage into that space, and that's called a pseudoaneurysm. So again, why does this happen? Site of access in the wrong place, typically a low stick in the pubis, and you can't compress it adequately. There's no ability to form a pseudoaneurysm if a high stick occurs because there's no soft tissues to wall it off, so it becomes a retroperitoneal hemorrhage by definition. If you use a femstop for primary hemostasis, meaning you put on a femstop, then pull the sheath and use that as primary hemostasis instead of a manual hold, you're more likely to get a pseudoaneurysm. Again, if you do a manual hold, but you have weak hands or you let off pressure too soon, but you confine it within those soft tissues, you can get a pseudoaneurysm. And of course, if someone did poor access technique with multiple punctures in close proximity, or did a closure device that subsequently failed, all of these can lead to pseudoaneurysm. Again, the primary mechanism of why this forms is the lack of a posterior bony structure to compress against, but you're pushing enough on the soft tissues to confine the bleeding to that space. This is what a pseudoaneurysm looks like on ultrasound, and you can see it's walled off by soft tissues. These can be very uncomfortable for patients, pulsatile mass in the groin. These are typically managed by either conservative treatment if they're small, or typically with a narrow neck and they're larger in size, we typically will compress them with an ultrasound machine and inject thrombin into them. If they're very large or have a wide neck, they may require vascular surgery intervention. All right, what about the most feared complication, retroperitoneal hemorrhage? This is by far the most feared and most serious femoral artery access complication. And this is due to blood actively tracking into the retroperitoneal space. It is immediately life-threatening. And as I mentioned before, you will often see no external evidence of bleeding. So people are fooled that are not experienced because the patient seems like they're becoming unstable, but there's no evidence of bleeding at the access site. And so people don't think they're bleeding. But by definition, the blood is going to go into that large space due to that high puncture site, not through the path of highest resistance. This is the key. If you suspect the patient may be suffering from retroperitoneal hemorrhage, do not send the patient to the CT scanner to make the diagnosis. Many patients have coded and died in CT scanners trying to make the diagnosis of a retroperitoneal hemorrhage. That's not what should be done. If you suspect that it's a retroperitoneal hemorrhage, treat it as such. Remember, a CT scan is not an actual therapy for retroperitoneal hemorrhage. So that's the wrong answer. The first thing is just like any trauma, because this is essentially a trauma. Stabilize the patient first. Put in a large central line if necessary. Fluids wide open. Place them in Trendelenburg position to improve head and neck blood flow. Call for blood and transfusion. Call your interventional cardiology team stacked for this, because again, we need to bring this patient back to the cath lab, get control internally, and then figure out what to do. Don't call vascular surgery in these situations because time matters. As I mentioned, it may take too long for the surgeon or the operating room to become available. And if it's a serious retroperitoneal hemorrhage, this patient will not survive by the time they get to the operating room. Or they have lost so much blood, they'll be so acidotic, they won't survive the subsequent operation. So why does this happen? The obvious reason is the high stick, as we talked about, in a non-compressible site. If you have a stick that's borderline high and you use a femstop, or you hold distally to the arteriotomy, you force the blood to track up instead of down because you're creating a manual barrier. And in some situations, even if the stick is not that high, it can track up through the inguinal canal and into the retroperitoneal space if you're holding it inappropriately. And obviously, other bad things like laceration of adjacent vessels, as I showed you earlier. This is what happens. The hole is leaking, and again, you're in this large cavity, and the blood fills this space. It's not going to track through that path of highest resistance. It's going to follow that path of least resistance. This is what you don't want to see, is somebody going to the CT scanner and getting a scout image that shows all of their intestinal contents shifted to the side, because this is all a gigantic hematoma. That's obviously a very serious situation. Here's what's called the bladder sign. And here's an example of what it looks like when you have a very large right-sided retroperitoneal hemorrhage. There's so much blood in the retroperitoneal space, the bladder is shifted to the side. So if you ever see this on an x-ray or in the fluoro in the cath lab, this is a retroperitoneal hemorrhage until proven otherwise. What are the signs and symptoms of retroperitoneal bleeding? Well, hypotension. The patient will often complain of back or flank pain. They will initially be tachycardic and sometimes bradycardic due to pain and vasovagal type of symptoms. They're often diaphoretic or sweaty, and they just don't look well. They typically will say, I don't feel well, and you try to ask them specifically what's going on, and they'll just say, I just feel really lousy. The problem is anemia is also a sign and symptom, but by the time you get the stat H&H back, it's often too late. They've lost a lot of blood and they could have already passed away. Nobody wants to have a code blue and a patient who has subsequently passed away only to be called by the lab with a critically low H&H value. It's too late at that point. So the key is not to wait for that. This is my rule of hypotension. If you're a fellow and you get called for hypotension, okay, after having a femoral catheterization procedure, the first thing you should do is go and see and examine the patient. I know it might be 2 in the morning and you're tired, I get that, but it's important to go and see and examine the patient. Sometimes hypotension is a minor thing, right? First episode, maybe it's vasovagal when they were getting a manual hold and there's pressure or pain in that area and it caused them to vagal, could be. But here's the thing, if you get called a second time for hypotension on the same patient, it is never something benign. It is always something sinister. Always think about retroperitoneal hemorrhage or cardiac tamponade if they had a stent procedure. Guide wires and whatnot can cause perforations and the patient can develop tamponade many hours later. So again, my rule of hypotension is if you get called for hypotension, go and see the patient. Very important. If it's the first episode and it looks vasovagal, it could be. But if it's a second call for hypotension, take it seriously. It is something sinister and you need to figure out what it is. The time that it takes you to figure it out is critical for the patient's survival, depending on what's going on. All right, let's move on to acute vessel closure and vascular compromise. So here's an example of a patient who had a right femoral access procedure and then subsequently lost pulses in their leg and had pain. And we took them back to the cath lab and the vessel is completely occluded. Now, why does this happen? Well, it can happen to the best of us, but it can happen for a number of reasons. This can be due to somebody doing a manual hold with excessive compressive force for too long on a diseased artery. This can be due to somebody dissecting the artery when they got accessed and that flap closed down when the sheath was taken out, or a closure device was placed that obstructed the lumen. Any of these can cause vascular compromise. The key is you would get called at this point because the nurse noticed that the patient had a loss of pulse or change in pulse, and the patient may have complained of pain, or the limb may appear pale. Keep in mind that this is not reliable because your patient may have some dementia or may be intubated and unable to communicate, and they may not be able to report pain. So monitoring of pulses is really important. If you find that the patient has lost pulses or has extreme pain or has some numbness or tingling or early paralysis of their toes or feet, call your interventional cardiology team right away. We need to get in, do an angiogram, and identify the problem. Okay, what about distal embolization? Well, this can occur due to a number of factors. It can be due to a disruption of a plaque by inserting catheters or wires, or thrombus formation that occurs around sheaths or catheters, particularly if the sheath is left in for a long time and the patient is not anticoagulated, or the vessel is very diseased and the sheath was somewhat occlusive, it can form thrombus. This can also be due to cholesterol plaque that's embolized, or again, migrating thrombus. It's critically important, again, to assess the pulses before the procedure. In this case, it wouldn't be you, it would be the nurse or the tech, but you would get called because the nurse noticed a difference in the appearance of the limb or a difference in the pulses. So the first thing you want to do is examine the patient and check for pulses. How does distal embolization occur? Again, it can happen due to a number of factors, but another one that can cause it, if someone has a sheath in place, before the sheath is removed, it's very important to flush the sheath. Now, a lot of people think that that means putting a syringe on the side port, sucking back from the sheath, and then pushing that back in the patient. That's not a good practice because you can have a little clot like this sitting inside the sheath. And if you simply pull back and then push in, that clot goes into the patient's artery like a little rubber bullet and travels down, can embolize to the toes or lower extremities. So it's always important to flush or aspirate back several cc's of blood and waste it, then flush the sheath with saline before removing it. So that's a common way that distal embolization can occur, and that's just bad technique. This is an example of cholesterol emboli. This is known as levator reticularis. If you ever see a picture of this on your board exam, that's what this is. And you see this little blanching type effect. You may see this in a patient in the recovery area. It usually takes several hours to days to occur, but you can see it fairly acutely. If a nurse calls you because of this, it typically is painful. But if the large pulses are intact, the treatment here is typically going to be some anticoagulation and antiplatelet agents and tincture of thyme. If the large pulses are gone, then this patient has significant obstruction of their vessels, and you need to call for assistance from your interventional cardiology team or vascular surgery team if that's appropriate for your site. All right, what about femoral nerve injury? This is not very common, but when it does happen, it'll really come to haunt you because it's very painful for patients. Remember, going back to that cadaver picture we talked about, there's the femoral nerve, the femoral artery, and the femoral vein. If we injure the femoral nerve, either by inappropriate hold, this typically happens if someone is not holding with their fingers, but more of a fist or an open hand, distributing that excessive force over a wider surface area, which is not just over the artery, but also over the vein and the nerve. That compression for 20 or 30 minutes on the nerve damages the nerve. And these patients will complain of a burning, gnawing, persistent pain in their groin that radiates into their thigh for weeks and even months. And these patients will haunt you because they're uncomfortable, and they'll call your office or your attending's office weekly and sometimes even daily, and it will drive you crazy, and it's avoidable. We don't want to do anything to the femoral nerve, okay? It's really important. So also, if a patient has a large hematoma or pseudoaneurysm, that can be compressing against the femoral nerve and causing pain. So if you see a patient who has this burning, gnawing discomfort, either as a post-procedural situation immediately afterwards, or in the office the next day or the clinic in a couple of days, the first thing you want to do, of course, is examine them, but get an ultrasound to be sure there's no pseudoaneurysm that's then pulsating against the nerve. If you don't see anything on the ultrasound, chances are it's a femoral nerve injury from either a manual hold or when they were obtaining access, somebody stuck a needle in the femoral nerve or injected lidocaine in there, something like that, and caused an injury. Okay, this is a common thing you get called for. You get called because someone had a manual hold or a closure device and there's oozing from the access site. How should you handle that? The first thing you need to know is to determine is this truly oozing or is this a more serious bleeding problem? So the way to determine that is to apply fully occlusive pressure as if you're doing a manual hold about 1 centimeter above the arteriotomy. If the bleeding stops, it's not ooze, it's actually coming from the arteriotomy. If the bleeding continues, then it's oozing. The reason for that is the tract or the skin, the blood supply is from tiny little branches that are coming from multiple supply sources. So if you obstruct the femoral artery by doing a manual hold and the bleeding stops, that means the main arteriotomy that the sheath was in is where the bleeding is coming from. You will not be able to stop the ooze by doing that because of the collateral circulation of that area from multiple locations. So if it truly is ooze, what should you do about it? By the way, first make sure it is, because here's an example of someone that was thought to have tract oozing and it was being treated as such, but the patient was on the larger side. And if they are obese or they have a lot of soft tissue, keep in mind you may not see pulsatile blood coming from the artery because of the depth of the artery. It may just be bleeding down inside the thigh. And here's an example of what you don't want to see, a CT scan of a very large left thigh hematoma. And all they saw was some oozing at the site. But this was a misdiagnosis. So you want to be sure it's not a serious bleed first. But if it truly is tract ooze, how do you handle it? The thing that I like to do is give 1% lidocaine with epinephrine. And you don't want to inject this into the main artery, of course, but you want to give this into the tissue tract and maybe a little bit at the skin site. This helps to constrict some of those small little capillaries and reduce that oozing. You can also use one of these hemostatic patches like a Hemocon, for example, although we kind of affectionately refer to these as placebo patches because they don't do a whole lot unless it's a very slow ooze. They can work well for venous ooze, not as well for arterial ooze. And finally, if it's really minimal, you can put on a pressure dressing. This is a bit of a complex pressure dressing, but what I mean by that is a wad of gauze with some of that white foam tape kind of stretching over it to kind of put a little bit of pressure. And again, you would not want to do that for true arterial bleeding, only for tract ooze if these other things failed. Okay, we're going to switch gears now and move on to radial artery access site complications. So again, your pager goes off and you get recalled to the cath lab recovery area by the nurse saying that this patient's radial access site is bleeding. Can you please come? Well, let's talk a little bit about radial anatomy because you need to know some to manage this. So the first thing to know is that your brachial artery comes down, obviously, in your upper arm, and then it splits off into basically 3 branches. The radial artery, which goes along the radius, the ulnar artery, which goes along the ulna, and then those connect together in a loop, actually 2 loops, and this is the palmar arch. There's also a 3rd branch, which is the interosseous artery, which is a source of collaterals to the hand and to the forearm. So that's kind of the blood supply. So importantly, if you're holding pressure on the radial artery, you have to make sure you're compressing on both sides of the arteriotomy, because if you only hold above, the backflow from the ulnar down through the palmar arch will back bleed, okay? And vice versa for the ulnar artery. So where do we get access? Ideal radial access is in the distal portion of the radius or radial artery, which is right over the radius and easy to compress. Similar in concept to the femoral location, we want that portion of the radial artery that's right over the bone so we can compress it. So this is an ideal location. We don't use closure devices because these arteries are so small. We typically use external compression devices. There are various brands on the market, but they all do essentially the same thing. They're typically some sort of bracelet-like object. This here is what's called a TR band, which is a very commonly used one. It basically has a Velcro attached watch band, if you will, and there's an inflatable balloon, if you will, or pillow in there that you can inflate air into, which pushes compression down on the radial artery. The most common complication that you are going to experience or get called for is going to be a forearm hematoma. Why does this happen? Well, it can happen for a number of reasons. Poor placement or insufficient inflation of the hemostatic compression device, an access site which is inappropriate. Just like in the groin, if we access too superiorly in the forearm, the radial artery dives deep and it's nearly non-compressible in some locations. Or if multiple needle punctures were performed when access was achieved, either below or above the site where the compression device is, it can cause those to bleed. And also perforation of the radial artery or its branches can cause the hematoma. Here's two examples of ways that this can happen. This is a TR band, which is placed inappropriately. That green dot in the middle should be basically over the site, but this is actually too high. So when this sheath is removed, that is going to compress the radial artery up here, but the ulnar is not compressed, and it will come back around and bleed backwards. So this is going to be a hematoma because the band is placed inappropriately. This is a site of access, which is very, very high. So this site of access is where the radial artery is very deep, and it's often not over the bone directly and is non-compressible. And also the TR band is also not well placed. So this hematoma is going to be because the site of access is not in the best place. Here's two examples of another reason for hematoma, vascular perforation. So here, either due to wire passage or catheter passage, the radial artery was perforated and bleeding occurred there. This is actually a bleed higher up. This is the elbow, and this is a small branch, either probably a wire exited there and caused bleed, and that led to a large hematoma in the forearm. How do you manage this? Well, if it's a small hematoma, less than 5 centimeters, you want to verify first the correct placement of the compression device. If it's not in the right place, we need to get it in the right place. Inflate the device fully, all the way, put as much air in it as possible, and then reassess. If the hematoma is now stable, then you can restart the typical compression site protocol that we have, which is a certain amount of time with the band on, and then they slowly start removing air. So just restart the process if you have control. If the hematoma is not stable, then you want to take off the compression device and hold manual compression. Remember, manual compression is always the gold standard backup. These devices exist to assist in the management of these patients and to reduce, manpower and use of resources, but they don't always work. And if it fails, the gold standard is manual compression. And again, if you're going to do that, you want to get I use 2 hands, and I put my thumb on the back side of the forearm and my index finger north and south of the hole. So I'm getting control from both sides so it doesn't bleed from either direction. That's very important. Once the hematoma is stable, reapply your compression device and you can try again. If it's already a large hematoma greater than 5 centimeters, remove that compression device. It's not working. Immediately get manual control. Get manual compression in place for at least 15 minutes before attempting to put any compression device back on. If it's bigger than this, then there's some other tricks you're going to use. Here's a classification and a treatment strategy that will help guide you. So when we talk about 5 centimeters, we're talking about the distance or the width of that from where the arteriotomy was. So again, a grade 1 hematoma is typically less than 5 centimeters. That can be managed by either adding some more air into the bracelet, making sure it's in the right place, possibly adding a second bracelet or manual compression. This can be uncomfortable, so always give your patient some sedatives to help them. If it's 10 centimeters or so, this is the type of situation where, again, I would insist on manual compression until it's under control, followed by placement of a new device potentially, as long as the hematoma is under control. Once it goes further than that, it gets more complicated. So here's an example of very significant forearm hematoma. We don't like to see this. There's the arteriotomy site. What's happened here is that either the band was taken off too soon or it wasn't positioned correctly, and blood slowly starts tracking under the skin and into the muscle up the forearm. And it's very painful. So once it gets past about the 10 centimeter mark or so, and it gets up into the forearm and there's muscular involvement, then we're going to use a blood pressure cuff. Now you can't use an automatic blood pressure machine because it cycles, it's designed to cycle. We need to get a manual cuff. We're going to pick a manual cuff and put it right about here. We're going to inflate it to a pressure which is about 20 millimeters of mercury lower than the patient's peak systolic pressure. Okay, so if they're running 120 over 80 right now, you're going to inflate it to about 100. You're going to leave it on there for 15 or 20 minutes. And of course, get control of this site up here manually first, and then with a compression device. Make sure that the hematoma is not getting bigger and not getting more tense. If it is, you don't have control. If it's not, then you can eventually take down this blood pressure cuff and the patient will end up with a very big bruise, but it will be under control. Now, they end up looking like this and it looks terrible. and you need to apologize and also educate whoever put the band on if it was on incorrectly, etc. But make sure after this situation, always make sure there's an intact waveform in these fingers. So put on a pulse ox machine and make sure you have a waveform. That tells you these fingers are not ischemic. If there's no flow in the fingers, something went wrong here. Maybe the ulnar's occluded and now the radial's occluded and they have minimal collaterals or something like that. That's really important to know, and it's an emergency and we have to deal with that. If the patient has numbness or tingling, then it can either be because the hematoma is so tight that it's compressing against the nerve, causing what's called a compartment syndrome, or the blood is tracked under the carpal tunnel and is actually compressing the median nerve. So if they have typical median nerve symptoms, think about compartment syndrome, think about carpal tunnel syndrome from blood tracking under that. And they may have to have a carpal tunnel release, believe it or not, for that. So you want to make sure the forearm and the hand is not tight. If the forearm and the hand are extremely tight and painful, that may be a compartment syndrome, and we'll talk about that. Of course, this area is going to be sore to the touch, but if they can move their fingers, they don't have numbness and tingling, and there's a good waveform on the fingers, it's just going to be an ugly bruise that'll take a few weeks to go away. So what is compartment syndrome? Compartment syndrome, of course, can happen in the lower leg, where most of us have heard of it before, but it can happen in the upper extremities. How do we diagnose it? Well, there's going to be extreme pain, much more than a hematoma. The forearm is going to be extremely tight, or that can happen in the hand as well. The hand will be extremely tight and painful. There'll be associated numbness and tingling. There'll be compromised distal signals. The pressure is so high, it's compressing on the nerve, the artery, and the vein. It will compromise distal signals. And they may even have some paralysis from that. So obviously this is not good. This person had to have a fasciotomy and a skin graft in their arm because of a complication. The hand, as I said, can get compartment syndrome. There's 10 compartments. They may have to actually incise those compartments to release pressure. Importantly, don't blow this off. This is a surgical emergency. Call a vascular surgeon or an orthopedic surgeon. Some vascular surgeons will do forearm intervention. Some vascular surgeons are not comfortable or trained to do that, and it's more of an orthopedic surgery. So depending on your facility and your resources, it'll be one of those two people, but you need to call them stat and insist that they come and see the patient, because you don't want to blow this off, because after a certain amount of time, there'll be actual tissue necrosis and permanent damage, which is of course bad. All right, so in summary, this was meant to be an overview of some of the basics of how to recognize and manage femoral and radial access site complications for beginning fellows. This is not an exhaustive review, as I mentioned, of every detail, but just the main bullet points to prepare you for life on call as a cardiology fellow. Importantly, some final thoughts. Don't be afraid to call your attending for advice or help. Asking for help is not a sign of weakness. It's a sign of diligence. And also get to know your interventional cardiology colleagues and use them as a resource for advice and assistance with post-cath related concerns. So this sounds stressful, but you know what? I think based on some of this information that you now know, hopefully you'll be able to manage these situations. And just remember, you got this. Thanks for your attention.